The following podcast is part of a certified educational activity titled In Pursuit of a Functional Cure for Hepatitis B, Monitoring Effectively, Optimizing Treatment, and Reducing Risk of Complications. Access the entire activity and complete the post-test at peerview.com/STZ860. Downloadable slides and practice aids are also available.
Good afternoon, everybody, and welcome to this program called In Pursuit of a Functional Cure for Hepatitis B. I dare say that's one of the greatest goals of modern hepatology in the world right now. We're going to talk about monitoring, optimizing treatment, reducing the risk of complications, some points about novel treatments that are being developed, which is a very exciting area right now. But first, I'm very pleased to be joined by two very distinguished colleagues, Dr. Nancy Rowe, Professor of Medicine and Director of Hepatology at Rush Medical Center in Chicago, and Dr. Paul Kuo, who is Professor of Medicine and Director of Hepatology at Stanford University Medical Center. Our goals for today are to expand your knowledge of the role of HPV serologic testing for monitoring disease activity and informing treatment of patients with hepatitis B, to equip you with the necessary skills to initiate evidence-based treatment of patients with chronic HPV infection to achieve a functional cure, which we'll define for you, and reduce the risk of complications. And finally, to provide you with the ability to implement expert-recommended monitoring approaches for treatment response, disease progression, and detection of liver fibrosis, cirrhosis, and hepatocellular carcinoma. And let's get right down to business with Professor Rowe, who will talk about serological markers and the utility in diagnosing and monitoring HPV infection. Nancy, take it away, please.
Thank you so much, Ira. So a little bit of epidemiology to set the stage. Up to 2.4 million individuals are chronically infected with hepatitis B, so this is no sizable burden. Many countries, hepatitis B rates are higher in men than women, but they have declined a little bit as a reflection of our vaccination protocols. However, especially in the United States, over 50% of individuals with chronic hepatitis B are from the Asian, Pacific Islander, or African descent, and of these, there are significant risk for liver cancer, and that leads to increasing health disparities in this population. The weighted average of chronic hepatitis B prevalence for all foreign-born individuals in the U.S. was about 3%. That doesn't sound that impressive. However, when you look at the amount of disease burden that generates, it's very significant. And of those, 60% of U.S. residents with hepatitis B are from areas like Asia or America, South America, or from Africa. And so really emphasizing that disproportional burden. Even worse, only 25% of infected individuals are diagnosed. Even diagnosed patients are not always linked to cure or care. And thousands of individuals die from hepatitis B every year. So really emphasizing the importance of diagnostics. So our next quest is to emphasize that diagnostics and screening have changed. So the CDC published in 2023 recommendations that are more in line with the 2022 ACIP vaccination recommendations. This is to make things more simplistic and to remove a lot of the stigma around hepatitis B screening. So now it is recommended that you get 3 tests: a hepatitis B surface antigen, an anti-hepatitis B surface or antibody, total antibody to hepatitis B core or total, so not IgM, and then you want to vaccinate anyone who is negative of all 3. The hepatitis B life cycle is really important because as we know that there's targets for every aspect of the hepatitis B life cycle and our drug development. But it's also important to recognize that this also generates the markers that we're going to use. Recognize that a hepatitis B surface antigen, which is what my component of this talk is going to be about, is generated from both CCC DNA as well as integrated DNA. And so that this is going to change a little bit in the life cycle of the person infected. So hepatitis B surface antigen in the natural history of chronic hepatitis B is important because it is a risk factor for hepatitis B DNA, which is why the WHO guidelines now give you an option if you do not have the ability to do PCR. It is a marker for risk for development of liver cancer in those that are hepatitis B surface antigen positive. And if you lose surface antigen, it actually is highly associated with lower risks of progression of liver disease and liver cancer. So surface antigen clearance is a highly desirable treatment endpoint. In natural history studies, as well as PEG and NA therapy, it is also very durable and has been associated with lower rates of liver cancer and liver decompensation in all three. Spontaneous NA and NA-induced surface antigen clearance, however, is unfortunately infrequent, with about 0.5 to 2% annually losing surface antigen. So not impossible, but not expected. This is a little bit of a busy graphic, but it emphasizes how surface antigen quantification changes in the period of your hepatitis B. So if you can see in the green bars, this is someone who is immune tolerant. So remember, high levels of replication, no inflammation, and quantitative surface antigen in this population is quite high. So these are E antigen positive individuals. Your quantitative surface antigen is coming from cccDNA. In those that are in immune clearance, you start to see some patients with lower rates or lower amounts of quantitative hepatitis B surface antigen. And in someone who is in a low replicative phase, such as a person who is, towards what we used to describe as an inactive carrier, now the quantitative surface antigen is quite low. And then in those that are E antigen negative, it is lower than those that are E antigen positive. And this is typically, again, from that integrated DNA, or at least about half of it is. So our guidelines, which are actively being updated, but our 2018 guidelines do define the role of quantitative hepatitis B surface antigen. I'm sure that the newer guidelines, when they were released, will help us clarify when we should be testing this. And this is obviously a question that you could ask for discussion. But in an E antigen negative individual, if your quantitative hepatitis B surface antigen is less than 1,000 and your hepatitis B DNA is less than 2,000, then this is consistent with inactive hepatitis B. And here is a time where you can use this to help differentiate a patient who might not be inactive. It also will predict the risk or the rate of spontaneous hepatitis B surface antigen clearance. When you're looking at treatment algorithms, its best role is in a pegylated interferon treatment algorithm, where if you're E antigen positive and your quantitative surface antigen declines or starts low, then you have a much higher rate of seroconversion. And because of that, we can use it as a futility rule, although it is a little bit challenging. And if you are E antigen negative and you have a greater than 1 log decline, that is going to also predict loss of hepatitis B surface antigen. Again, not frequent, but it helps you understand the treatment course. And this is really what the AASLD guidelines in 2018 outlined the role of quantitative surface antigen. This is a study, RETRACT-B, that looked at challenging some of these predictive rules. You can see in this that if you were likely to lose surface antigen after 4 years, your ethnicity and your amount of hepatitis B surface antigen could predict the chance of that and the durability of that. So if you were Caucasian and your quantitative hepatitis B surface antigen was less than 1,000, you had a 41% chance of loss, and you could definitely stop your nucleic acid. If you were Asian, however, that threshold dropped to lower than 100, and then the chance of surface antigen loss and durability dropped to about a third. So predictive rule is a little confusing, but still a very strong role for quantitative surface antigen measurement in a patient who's considering stopping their nuke therapy and hoping for good outcome. You can challenge this even further, though, in this study that looked at a population that had levels less than 100. There were still individuals that relapsed. And if you push that quantitative surface antigen down to now a threshold of 40, you might have a better predictability and better durability. So again, it's a smaller percentage of the patients, but it is a little bit more predictive. And so when you're talking to your patient about doing something that is likely to have longevity, you want to be as accurate as you possibly can. There is quantitative surface antigen approved in the U.S. That was another challenge. It's hard to use something that's not available to you, but we now have approved testing. And I would encourage you, as I'm sure my colleagues would, that you should be using this at various time points, not just in alignment with what the AASLD guidelines suggested in 2018, but natural history. It's going to help you identify an active carrier. And here it's going to help reassure both you and the person in front of you about their durable response and, probably lower rates of complications. If you're looking at using quantitative surface antigen during therapy, it definitely has strong association with how you're going to use pegylated interferon, both leading to encouragement for a patient to stay on, as well as futility in a patient who's unlikely to have a good response. And it also allows you to better able to identify a person during NA therapy that might lose quantitative surface antigen.
Thank you, Nancy. Very nice. And now it's my opportunity to talk to you about initiating antiviral treatment for chronic hepatitis B and the goals of therapy. There'll be more than that in here, but it mainly centers around that theme. So the goals of therapy for HBV infection are really self-evident to everybody in this audience. We want to improve liver histology, decrease serum HBV DNA levels, hopefully shut replication down completely, induce a seroconversion initially in E-positive patients with loss of E antigen, which represents a milestone in the natural history of that patient, even though it doesn't eliminate the carrier state or potentially E antigen negative chronic hepatitis B. It's still a good thing when that happens in E-positive patients. We want to normalize ALT, and all of this is in the interests, obviously, of prevention of mortality, cirrhosis, and HCC. This shows the natural history of hepatitis B in its phases, as has been published so frequently in the literature over the years, from what was once called the immune tolerant state. Now some prefer to call it a chronic HBe negative infection, although I'm a little troubled by that because you're still infected no matter what phase you're in. So we won't worry about the terminology today, but I think conceptually the concept of immune tolerance still prevails in many circles as pertaining to E-positive patients with very high viral levels, but minimal or no inflammatory liver disease. Then there's the immune clearance phase, which correlates with active histology, inflammation, progressive fibrosis, possibly culminating in cirrhosis if it lasts long enough and isn't interrupted, followed by the inactive carrier state, which can then revert to E antigen negative chronic hepatitis B with its active inflammation and generally more moderate viral levels, as you know, than an E-positive disease, by about 2.5 to 3 logs lower, we would say. And finally, eventually, lucky patients clear HBsAg completely, which is what we call functional cure. So on the right, again, functional cure means sustained HBsAg clearance. And the ideal functional cure that we're aiming for with a number of new therapeutic modalities under investigation at the present time is clearance of covalent closed circular or CCC DNA, which is the template from which the entire life cycle arises. Why aim for functional cure of HBV infection? Why is it better to clear HBsAg than perhaps to stay on relatively very well-tolerated medications such as we have now and maintain an inactive HBsAg positive state? Well, there are all kinds of reasons that are shown here. We avoid the long-term risks of NA or nucleotide analog or nucleoside analog toxicity. Although those have been proven to be minimal, they're not negligible. Reduce costs associated with long-term or lifelong therapy, avoid risks of hepatitis flares, the patient discontinues therapy or for whatever reason stops it, reduce the risk of reactivation years after treatment stop, particularly with certain types of immunosuppressive or anti-inflammatory therapy, including but not limited to chemotherapy. And finally, and I think the major goal here would be to further improve clinical outcomes. And as I indicated in the footnote, Professor Yip, who does amazing population studies in hepatitis B populations in Asia, along with authors of other papers, have demonstrated that you're better off clearing HBsAg because even when you're well controlled with chronic antigenemia, you have a higher risk of HCC than those who are fortunate enough to clear HBsAg. So who to treat? What's the current landscape? Well, this is something that I think almost everybody in the room is fairly familiar with. This is the AASLD guidance on HBV therapy. We've been waiting for some time now for a new version of this. I have no inside knowledge as to when this is happening. But what we see here is the E-positive schema, in which there is only one unconditional criterion for treatment, and that's a combination of ALT more than twice normal, which I regard as a holdover from a much earlier era with interferon and the early nukes, when there was a much higher chance of E antigen seroclearance with ALTs that were particularly high, specifically above twice normal, as opposed to just a little above normal or actually normal. And in general, there were better responses to therapy with interferon, for instance, or the earlier nukes with ALTs that were particularly elevated. I think now we're getting to a time when we really want to suppress the virus in the long term, and that's become the major goal. And I'll get back to that actually repeatedly. And the other unconditional criteria for treatment, because it's a duet here, is an HPV DNA above 20,000, which most E antigen positive patients have. That changes in E negative patients to 2,000, but otherwise I'm not going to show you the separate E antigen negative slide. The main theme to take away here is twofold. First, the gray boxes illustrate a bunch of nuances centering around things like findings on liver biopsy or other evidence of at least F2 fibrosis, as shown on the bottom, or particularly active inflammation, which would trigger you into treating if it's otherwise not clear. And then on the right, we have the so-called immune-tolerant patients with ALTs that are less than normal, E-positive, often astronomical levels of HPV DNA that can exceed 1 billion copies or units per milliliter. And the guidelines continue to say that we shouldn't treat those generally young patients, which has become somewhat controversial as we start to think about this more as a viral infection that needs to be controlled, not something that around which that centers entirely around suppressing inflammation or progressive fibrosis. So I already alluded to the idea that perhaps the treatment criteria should be expanded, and I actually literally mentioned that we're hoping in the next rendition of the guidelines they are. In fact, there are some guidelines outside of AASLD, and I should say, by the way, that the European criteria are fairly similar but are more expansive with regard to treating people over 30 but with normal ALT levels and high viral levels. So already they had started in that rendition a few years ago as well to be more expansive with regard to controlling viremia, even if there isn't necessarily a lot of liver disease going on. Well, increasing attention to this concept of treatment criteria expansion in hepatitis B has focused on the problem of oncogenesis and early events in the natural history of chronic hepatitis B, which actually begin very, very soon after infection, within days or weeks, related to HPV integration, a theme that I assume that all of you are familiar with, and the genetic dysregulation that can result over a long period of time that has pretty much been linked in the literature in many studies to oncogenesis by either promoting the activity of tumor promoter genes or perhaps if HPV integrates next to a tumor suppressor gene, interfering with that function. And chromosomal translocations, things like that we don't want in our patients, even arguably if they don't have active inflammation or fibrosis at the time that all of this is going on in their cells. So my schema for thinking about this is that there's an evolving perspective on treatment of chronic hepatitis B, moving a bit away, perhaps a lot of way away for many of us, to the idea that we treat chronic hepatitis B not so much as an inflammatory liver disease in which therapy should be based on liver inflammation and fibrosis, but as we do with other viruses like HIV and hepatitis C, treat even in early disease independent, or less dependent at least, on indices of inflammation and fibrosis. Two very important papers were published in the ID literature a couple of years ago that bear on this. This is a study that looked at 28 patients treated with antiviral therapy, 28 that is to year 1, 7 followed out to year 10, looking at the integration burden in the liver cells and hepatocyte clone size. Clonal expansion of cells, after all, is a very plausible precursor to carcinoma, in this case hepatocellular carcinoma. So on the top line, we see a pair of figures showing first HPV DNA integrations on the left and maximum hepatocyte clone size on the right, with statistically significant reductions over a 1-year period in the aggregate in the 28 patients followed up to that time point. Going out to 10 years, we see a nearly statistically significant, probably or perhaps not so because of the smaller sample size, in DNA integrations, and still a statistically significant reduction in hepatocyte clone size with prolonged antiviral therapy. There's always nothing better than a placebo-controlled trial, and this is another paper, actually in gastroenterology. I mentioned the ID literature for the other paper, but another very impactful paper that's been widely quoted, looking at a decrease in HPV DNA integrations in patients treated with 3 years of tenofovir, showing a statistically significant reduction in the tenofovir population, but not in the placebo recipients. So that begins to tell us what prolonged antiviral therapy can do in terms of possibly interfering with downstream hepatocarcinogenesis many years later. The problem with all of this that always comes up in discussions of the issue is that we're never going to have a large enough trial lasting long enough to prove that treating patients who don't meet the current treatment criteria is going to make a difference. And that's the main reason, as I perceive it, that this argument goes on and on. In fact, we do have more expansive guidelines. That China has by far the greatest burden of HPV-infected people of any country in the world, and they came up with a very interesting and important guideline in late 2023. And the first thing you notice is that HPV greater than 2,000 or 20,000 is gone. The inflection point for this guideline is any detectable HPV DNA, which I think is a remarkable development, is unique among the guidelines so far. And they simply say that if HPV DNA is detected, of course, you treat if the ALT is high unless there are other causes. But most notably, from my point of view, if the ALT is normal, we go down to age over 30, and they say, treat those patients. Still saying under 30, perhaps not. I do wonder if that's a little arbitrary, and I'll get back to that in a moment. The biological events are still going on in the livers of younger people as well, that could be harmful even decades later. We also have, very importantly, very recent World Health Organization guidelines for the treatment of chronic hepatitis B. And the most remarkable feature of this guideline, is here, where only one of the 4 treatment criteria requires any HPV DNA at all. Now, I surmise that this was probably done in deference to the fact that there are many areas of the world where HPV DNA is very difficult to access. So let's look at their criteria. The first one is significant fibrosis, at least F2 or cirrhosis F4, regardless of DNA or ALT levels. The second one, which looks familiar, is an HPV DNA of more than 2,000 and an elevated ALT. The third is the presence of co-infection with any of the other viruses that we worry about, family history of liver cancer, which does increase the patient's own risk of liver cancer, immune suppression, comorbidities, and extrahepatic manifestations like glomerulonephritis or vasculitis, polyarteritis, for example, which we seldom see anymore, but certainly can still happen. So they say, again, the ALT level has to be high to treat those patients, inferring indirectly, if not explicitly stated, don't treat if the ALT is normal in those patients. And then the fourth criteria is, again, not requiring a DNA, but persistently abnormal ALT levels alone in the presence of chronic hepatitis B and in the absence of access to HPV DNA assays. My colleague Doug Dietrich came out with a guideline with some distinguished colleagues last year. It's called the SABA guidelines, a simplified treatment algorithm for the hepatitis B patients. And after the usual workup, they came up with an age over 30 and DNA more than 2,000. Even if the ALT is less than normal, warranting treatment. We've seen that before about the age of 30 in the Chinese guidelines, as I showed you. But also treat younger patients with DNAs above 2,000 if the ALT is above normal. No more twice normal in any of the recent guidelines. And then defer treatment if the age is under 30 and the ALT is more than if the DNA, is more than 2,000, but the ALT is less than normal, or if the DNA is less than 2,000, so still a DNA cutoff. And then I humbly submitted with a colleague at NYU another algorithm of our own. You'll forgive me for putting this in, but it reflects my own feelings. And here we have no age 30 cutoff, certainly no twice normal ALT provision, an ALT, a DNA of above 2,000 regardless of ALT. So here we have the idea that we should treat those patients. Again, we don't have an age cutoff here. And I think fairly obviously, if some patients have a DNA of less than 2,000 but have an ALT that's above normal in the absence of another explanation, which we always have to seek, first and foremost with the hepatitis D test, but everything else as well, we should treat those patients. And I think it's difficult to argue with that. When can treatment be stopped? Well, Nancy talked about this a little bit. With PEG interferon, the defined duration has been 12 months for E-positive and E-negative patients, seldom used in the United States, but perhaps more frequently in some areas internationally. And of increasing interest, I should add, in the armamentarium of drugs that people are testing in combination with antiviral drugs in the field of novel therapeutics for hepatitis B. Nukes until the treatment endpoint. We'll talk about what that should be, but traditionally it's been HBsAg clearance. E-antigen seroconversion. We used to say that if you treat an E-positive patient, you should go for at least 12 months beyond. Some would say 2 to 3 years to further decrease the risk of relapse. And then you can think about stopping your therapy, although many of us do not, for quite some time. E-negative patients, indefinite therapy, or until S loss has been the traditional view, and cirrhotic patients, lifelong therapy. My personal take on the current situation, in which we have evidence that if your HBsAg level is less than 100 after several years or numerous years of nuke therapy, that you can consider stopping, because it seems to actually promote HBsAg clearance in more patients than would clear HBsAg if they continued on therapy. The idea presumably being that if you liberate a hitherto suppressed immune response with the reappearance of virus after all those years of viral suppression, and now your exhausted immune system wakes up and knocks out the infected cells and promotes the clearance of HBsAg, and Nancy showed you the data on that. I think this should be offered to patients when we get our quantitative HBsAg testing done serially over time, as we discussed earlier, and we have an informed discussion with the patient that should be data-driven to the extent that patients can understand it, and I think if you take the time, they can understand it quite well. And it should include, again, the result of an S level quantitatively. Shouldn't be offered at all if the S antigen level is over 100. I think even the most aggressive discontinuers in the field would agree with this. Avoid stopping in cirrhosis pending further studies. We don't want to have a flare that can occur in these patients, and Nancy showed you that, that can have catastrophic results. Importantly, critically indeed, the decision to stop should be as much patient-driven as clinician-driven. I would never hammer a patient about telling them to stop therapy if their HBsAg is 30 or 40. If they're reluctant to do it, I would defer immediately. In fact, in my own practice, I'm really not all that proactive about stopping because I do fear the flares that can occur, albeit very uncommonly, particularly in people without cirrhosis. But with cirrhosis, I'm at the present point, I would never stop unless a patient has cleared HBsAg for a long time. And then you have to monitor for flares if you do choose to stop, or I should say if you and your patient choose to stop together. And that monitoring should be fairly close, particularly in the first year. And you have to be quite ready to restart therapy, perhaps if the DNA gets up to certain levels that people are writing about in the literature these days. I would in fact restart for almost any relapse of viremia. These are new targets for HBV. There are so many of them superimposed on this very nice picture of the viral life cycle. But the two that have been reported out the most in terms of completed studies are the inhibition of proteins translation, not only by siRNAs, but also we should add antisense oligonucleotides, and core inhibitors, otherwise known as capsid assembly modulators. There's a lot of excitement about genetic therapies, either direct genetic therapies by excision or non-excisional approaches, by silencing DNA. Even integrated DNA can be silenced with some experimental drugs, investigational drugs right now. But that's futuristic at this point, and I think we'll see more about that in the next several years. Very exciting concept. Of course, there are entry inhibitors. We're used to the polymerase inhibitors. And very importantly, a number of types of immunomodulators that are displayed here are being tested either by themselves or more commonly in combination or in some sequence with antiviral drugs of one type or the other. We also have HBsAg release inhibitors called NAPs, nucleic acid polymers, which have appeared quite promising but haven't progressed to the ultimate mature phase of clinical trials that would be ready for licensure. But we hope that happens, or at least to see more studies to see if the early promise can be borne out. And there are some reports about that here at this meeting. So what are antisense approaches being studied for HBV? Well, I've already mentioned that this centers around small interfering RNAs, as well as antisense oligonucleotides, or ASOs for short. And small interfering RNAs are double-stranded sequences of RNA that are processed and escorted into a multi-protein complex by an enzyme which is very important called dicer. And within that RNA-induced silencing complex, an enzyme called argonaute work together with other enzymes to unwind the double-stranded DNA and to target a selected mRNA, in this case in particular, the messenger RNAs that represent all of the transcripts put out by HBV. which is always making messenger RNAs from the cccDNA in the cell nucleus. Although this inhibition process, as well as anything pertaining to antisense drugs, occurs in the cytoplasm. I have little photos here that you can look at later with attribution to a very nice paper on the bottom. ASOs, or antisense oligonucleotides, in contrast, are single-stranded RNAs that target mRNAs, again, belonging to the virus, with the potential and actually having demonstrated profound suppression as of siRNAs of all of the protein products of the various transcripts that come from the nucleus of mRNA, and are degraded by RNase H, which is a mechanism that doesn't pertain to small interfering or short interfering, I should call them, RNAs. So some contrasts are that ASOs, again, are single-stranded versus double-stranded for siRNAs. More frequent dosing, at least so far, weekly for bepirovirsen, which is the ASO that's been most heavily studied by far, versus Q4, or even in one case, imdusiran, an every 8-week regimen with marked decreases in HBsAg for both of these classes of drugs. The ASOs stimulate toll-like receptor activity, particularly TLR8, and so are somewhat more pro-inflammatory, which may arguably contribute both to efficacy potentially, but also potentially to side effects. More ALT flares with ASOs, probably because of the immune stimulatory activity that they have. Higher AE rates with ASOs, as just mentioned. Similar rates so far, numerically at least, in terms of degree of log reduction of HBsAg, which is the primary antiviral effect that we're looking at, although we look at all of them together, and higher rates of clearance thus far with ASOs. Again, we talk a lot about whether this is due to the additional immune modulatory properties, but all that has yet to be completely worked out. So this is the largest paper, and it's been published in Lancet Gastroenterology Hepatology by Professor Yoon last year, called REEF1, which was an siRNA plus a capsid assembly modulator, or I should say plus minus. And don't get too confused by the arms. We're going to focus almost entirely in this discussion on the patients who got, it's called a dual because there's a nuke still being given to these patients at 200 milligrams, the highest of the 3 doses that were studied. There was also a combination group called the triple group that got the siRNA plus the plus nuke plus the capsid assembly modulator. This was a 48-week treatment period, and patients were followed out to the primary endpoint at 24 weeks. The primary endpoint here were meeting various criteria for discontinuation of nukes, which included an HBsAg level less than 10. You were allowed to stop if you had a little bit of detectable HBsAg still left on a quantitative assay. I just want you to focus on that 200 milligram group that I underscored before, which had the most profound decline in HBsAg, which occurs rather sharply in the early phases and then levels out, but not completely. Some suppression additionally is still going on at the 48-week time point. But then all of the siRNA curves have looked like this, where there's a gradual, slow return, although there was an exciting presentation at EASL just last spring where it was shown that even years later, the levels of HBsAg haven't gotten back entirely to where the patient started, a very important paper. Certainly this class of drugs is still in the arena. However, although 75% achieved marked HBsAg reduction, I believe only about 3 patients reported in the New England Journal paper actually were clear of HBsAg at 6 months of follow-up after discontinuation of therapy, and 2 of those were still on nukes because they hadn't met the nuke stopping criteria. So rare sustained HBsAg clearance. Bepirovirsen was granted fast-track status. I'm going to show you the bepirovirsen data. That's our antisense oligonucleotide. In February 24, and there are 2 phase 3 studies that actually are called B-Clear that were reported in the New England Journal by the same Professor Yoon and his colleagues recently, about a year ago. There were 2 phase 3 studies. That was a phase 2 study that I'm going to show you called B-Well-1 and B-Well-2, which are ongoing with estimated completion in late 2025. And we have a nice animated demonstration of how bepirovirsen works. Would like to turn that on now, please?
Hepatitis B virus, or HBV infection, is a serious global health issue with more than 250 million chronic carriers. HBV infection can cause liver diseases such as chronic hepatitis, cirrhosis, and hepatocellular carcinoma. Persistent suppression of the HBV surface antigen is necessary for a functional cure for HBV infection. However, patients with chronic HBV infection rarely have HBV surface antigen loss after treatment with currently approved first-line therapies. Antisense oligonucleotides, such as bepirovirsen, work by targeting all HBV mRNAs in chronic HBV infection and act to decrease levels of viral proteins. Results of a Phase 2b trial showed that when giving a dose of 300 milligrams for 24 weeks, around 10% of patients treated with bepirovirsen with or without stable nucleoside or nucleotide analog therapy achieved the primary study outcomes of hepatitis B surface antigen and HBV DNA loss for 24 weeks after the end of treatment. Bepirovirsen is now being studied in Phase 3 trials. Suppression of hepatitis B surface antigen and HBV DNA is essential to reduce viral replication, decrease liver inflammation, restore immune function, and prevent the progression of liver disease, ultimately leading to better clinical outcomes and improved patient quality of life. Other antisense oligonucleotides and small interfering RNAs are also being studied for the treatment of HBV infection.
Thank you. So let's look at the Phase 2 study in the New England Journal from a couple of years ago. Actually, it was published contemporaneous with AASLD that year, very memorable. And it's the efficacy and safety of bepirovirsen, which you've just heard about in chronic hepatitis B, and the first study to actually demonstrate an increase in the functional cure rate of interferon over nuke analogs. There were 4 arms in the study, and again, I'm going to make it easy by just having us focus on one of the arms, because it turned out to be the most effective, and is the one that's been carried forward to a number of other studies, including the ongoing Phase 3 B-Well studies that was mentioned a moment ago. And it's the bepirovirsen 300 milligram weekly, subcutaneously, for 24 weeks. And again, this looked very complicated, but I just want to focus on the 300 milligram dose. We're going to forget about the others for now. And what we see is that at the end of treatment, this is looking at HBsAg that is undetectable at the end of therapy, 26%. And at follow-up to week 24, 12%. Here we have 29% and 14%. So this reflects very substantial relapse rates, but on the other hand, historically significant, the first demonstration of a novel regimen like this that can at least induce functional cure in some patients, and therefore serves as a platform on which we can now try to do even better in the future. And that's the basis, certainly, of this very robust ongoing program. Now, the primary outcome was achieved in 9 and 10%, 9% in those receiving nukes, and 10% in those not receiving nukes, corresponding to the upper and lower groups here. Well, what's the difference? The difference is the primary outcome was very rigorously defined. You had to have undetectable HBsAg and DNA at the end of treatment and at every follow-up time point all the way out through and including follow-up week 24. And some patients had blips, and that accounts for the difference in the numbers shown here and those shown out here. The truth is, we don't really care much about blips as long as they go away. Of course, time will tell whether a blip on the way to a negative follow-up week 24 assay may correlate with subsequent reactivations, but we're not even close to having the answer to that. I predict that it won't be much of an issue. Now, very importantly, baseline quantitative HBsAg, which Nancy discussed so nicely, of 3,000 units or less, was a very strong inflection point separating out people who responded to people who didn't. And that's a theme that's emerging from a number of other studies that are in various parts of Phase 2 that have reported out at least some data, that it's a much easier target when you're dealing with a patient with a low quantitative HBsAg at baseline. That's intuitively certainly plausible, and that's what's bearing out so far. There was, of course, a very detailed safety profile reported in the New England Journal paper, and the list is here. And all of these reflect, we believe, the shall we say, immune activating or pro-inflammatory might be a better word, properties of the antisense drug, which again does have particularly seemingly some activation of one of the toll-like receptors, as said. There are data being presented bearing on BEPI, which we call it in our inner circles at AASLD 2024. And the two that I would emphasize are the profiling of how HBV genotype, this is very important, correlates with different outcomes in this program from the Be Clear study. And even more exciting potentially for the future is PK and PD modeling addressing the question of whether there might be a benefit to adding an siRNA to BEPI in sequence to get even more profound suppression of viral replication and hopefully higher rates of functional cure. Very exciting. GSK, which makes BEPI and has run a very robust program with several studies, and I'll show you another one in a moment, has acquired the siRNA, the data from which I've shown you, which used to be called JNJ 3989, and these are the two drugs they're going to use in upcoming studies. The other study that I'll show you on BEPI was actually authored by our very distinguished international colleague, Professor Maria Butti, who's sitting right in the first row. Hope you don't mind, Maria. This was in a major journal. I think it was in The Lancet just recently, and it had two arms. It was BEPI 24 weeks follow. This is sequentially, not in addition to interferon at the same time, 24 weeks follow-up. So a 1.5-year study versus BEPI 12 weeks, but PEG again for 24 weeks and 36-week follow-up to even out the durations over which patients were officially enrolled in the study. Although what we have here are 24-week follow-up data for both arms. And let's look together at the blue bars. And again, Arm 1, counterintuitively perhaps, is the 24-week study, and Arm 2 is the lower duration of BEPI study, part of the study, 12 weeks. We'll look at the stratifications for HBsAg level in a moment. And we can see the rates of HBsAg clearance here, end of treatment virologic response after the BEPI phase, 23% in Arm 2, 35% in Arm 1. But as you go out to the PEG interferon phase, you do see some declines, and at the end of sequential therapy, the primary endpoint 24 weeks later, you're left with 9% and 15%, which doesn't look all that different from the numbers in Be Clear, which had been published in the New England Journal already. Now, there are a lot of nuances to this, and the first question you might ask is, why were the results better in the 12-week group for BEPI than the 24-week group? And as Maria lays out very clearly in the publication, the COVID lockdown had a much more profound effect on the 24-week BEPI group because those patients got locked down just as PEG interferon dosing was beginning instead of after it had already started and was well underway in the other group. And that resulted in a number of patients who missed a number of doses of their PEG interferon. So we think that's what happened here. But the real point of this is to look at the relapse rates between the end of treatment virologic response, and this is the end of total treatment, not just the BEPI phase. And we can see that we go from 17% in the all group, forget about the stratifications, down to 15% in the 12-week BEPI arm. The relapse rate was higher from here to here in the 24-week arm, but again, this may have been confounded by the factor that I mentioned earlier. And this has raised the idea that interferon, although it didn't seem to accrue additional responders during the interferon phase following the BEPI phase, may reduce the risk of relapse. But the numbers are pretty small here, and we really have to study this again if we want to pursue that. And again, it is in vogue right now to be looking at interferon. Whether that will be done in this particular program, I do not know. If we look at the stratifications for HBsAg levels at baseline, we see that patients at less than 3,000 have much more robust responses than patients in the total group who had many patients above 3,000. And patients with less than 1,000 do best of all. Again, this is a theme that's emerging from a number of these kinds of studies with novel agents. One more study with an antisense drug, imdusiran, followed by interferon, showed a very marked drop in a 24-week interferon part of the study, which followed 24 weeks of their siRNA. And this is very exciting. We don't know what the biological message here, but belatedly PEG interferon seemed to stimulate likely some kind of additional immunologic response that resulted in a big drop. And this is being pursued, and in fact, I have another presentation here as follow-up to that study. So novel classes of drugs being investigated include antiviral and immunologic approaches. Time precludes my going through them individually. And there are certainly many other studies that we haven't been able to do justice to in the relatively limited time that I had available. But please do note that many of these kinds of agents are being studied either on their own or increasingly in combinations, trying to harness both the antiviral properties of novel drugs as well as heightening the immune response, which we think will ultimately be an important part of how we eliminate this problem and induce functional cures in more and more people. So with that, I'll introduce my colleague, Paul Kuo, who'll talk about monitoring patients for cirrhosis and HCC. Paul?
Thank you, Ira, and good afternoon, and thanks so much for joining us. Such an exciting era. So we'll go ahead and get started here. So let's talk about the long-term complications of hepatitis B. And again, they're really related to the ongoing necroinflammatory activity of the hepatitis B virus that leads to fibrosis, subsequent cirrhosis, and hepatocellular carcinoma. Hepatocellular carcinoma is sometimes even not in the presence of cirrhosis, and this is one of the unique features of hepatitis B. So what are the factors that increase the risk for hepatocellular carcinoma? So the most common is cirrhosis, and this is really from any cause. It's an important risk factor for hepatitis B associated HCC, and as you know, cirrhosis, regardless of the etiology, is a pre-cancerous condition. And the reported risk is anywhere from 2.2 to 4.3 per 100 pack year, or 100 person years here, and a little bit lower in those without cirrhosis. What about other risk factors that we see with hepatitis B? Well, age, male sex at birth, heavy alcohol use, and we do have to screen our hepatitis B patients for alcohol use. Smoking, diabetes, metabolic syndrome interplays very closely with hepatitis B, as does a family history. A little less common aflatoxin exposure, but well described. Viral level, and especially hepatitis B DNA levels that are very high. Again, hepatitis B is a carcinogen. If you have high levels in the bloodstream, high level of carcinogen. E-antigen status, genotype, co-infection with Delta, and hepatitis C co-infection are all also risk factors. So what's the prognosis of someone if they are diagnosed with hepatocellular carcinoma? Well, we will have at this meeting many presentations, and the overall prognosis has actually improved. Our systemic therapies are actually really making an impact in those with hepatocellular carcinoma, but the prognosis overall still is somewhat poor. Overall, 5-year survival, 21%. And that's largely because individuals who have hepatocellular carcinoma often present at an advanced stage of disease. And when we care for individuals with hepatitis B, it is our responsibility to ensure that patients are undergoing appropriate surveillance for hepatocellular carcinoma. And this is so that we can diagnose early stage HCC, where we have far more, a larger group of treatment options, including curative options. Just again, a word about the hepatitis B DNA level and long-term outcomes. This is the REVEAL study, the very classic study from the Taiwanese townships. And again, what this showed, and you can see it in both graphs here, is that a cumulative incidence of hepatocellular carcinoma, as well as a relative risk of cirrhosis, all increased across this biologic gradient of HBV DNA. And when I sit down with patients in the clinic and discuss their viral levels, particularly as they get older, and Ira went over just beautifully why this is so important, I tell individuals that hepatitis B is a carcinogen, and WHO has classified it as a carcinogen, and when we talk about treating hepatitis B, we obviously want to try and reduce the exposure to this as significantly as we can, ideally down to 0. And so one of the most important things that we do, which has informed our prior treatment guidances, is in a fibrosis assessment. And again, we used to typically do liver biopsies many years ago. This is obviously the gold standard for detecting hepatic fibrosis with chronic hepatitis B, as well as to confirm HCC if required. That is, it doesn't mean imaging criteria, but again, this is an invasive procedure, and so we typically rely now on non-invasive assessments of fibrosis, and there are a variety of them. They're shown here in both columns here. And again, we can rely on serum biomarkers. Some are as straightforward as the AST to platelet ratio, which is the APRI or the FIB4. But we have other serum markers of fibrosis, which we can use. And again, we have imaging tests as well that we can use to assess hepatic fibrosis. And these include various forms of elastography. This can include vibration-controlled transient elastography, or VCTE, magnetic resonance elastography, and of course there are others as well with ultrasound, such as shear wave or acoustic radiation forces elastography. What about those individuals who develop hepatocellular carcinoma? And what this shows is a cohort of individuals who developed hepatocellular carcinoma. And what they did was they went back and they looked at individuals to see if they were within criteria by various organizations. And these include the AASLD, EASL, and Apostle. And what you can see in this group of individuals who developed HCC, 46% were outside AASLD criteria, 34% outside EASL, and 64% outside of Apostle criteria. And the takeaway from this was that a large proportion of patients who develop HCC do not meet our current guidance criteria for antiviral therapy. Now, happily, Ira shared with us updated guidances, and the thresholds are clearly falling. WHO, Chinese guidelines are all now lowering the thresholds. And again, treating hepatitis B reduces the risk of hepatocellular carcinoma when you give nucleotide analog therapy. And it's one of currently our few interventions to reduce the risk. And as shown here, antiviral therapy reduces the risk by about 70%. And this was a trial that was published. And these were individuals who were in the indeterminate phase. That is, they weren't neatly classified. And this was 855 individuals without advanced fibrosis, 14 international centers. They looked at inverse probability of treatment weighting to balance treated and untreated individuals. And you can see here, the cumulative incidence of hepatocellular carcinoma over 15 years was in untreated individuals as high as 19%, and those who were treated, 9%. And there was higher HCC incidence observed in men, those who were older, e-antigen positive, and again, HBV DNA greater than 1,000 units per ml. And again, we have to be very mindful of the procarcinogenic potential of hepatitis B as we manage our hepatitis B patients through the coming years. Surface antigen loss with nucleotide analogs is a great event. It just doesn't happen often enough. But when it does, then you have fewer rates of hepatic events, you have fewer risks, or you have a lower risk of development of hepatocellular carcinoma. And this was a very nice study that looked at individuals who were hepatitis B DNA positive, suppressed HBV DNA, and happily who cleared surface antigen. And as you can see, the lowest rates of hepatic events or decompensations, as well as hepatocellular carcinoma, occurred in those who were surface antigen cleared. That is, they were now hepatitis B surface antigen negative. And again, this is really the holy grail for our therapies now as we explore novel therapies. We see it rarely with nucleotide analogs, and hopefully we're entering an era where we're going to see higher rates of surface antigen with our novel therapies. What about screening individuals? So the impact of screening is very favorable on the stage of hepatocellular carcinoma at the time of diagnosis. And in this very classic trial from China, there were 18,000 individuals with chronic viral hepatitis, the majority hepatitis B, who were randomized to screen or to a control. And these individuals who were receiving screening were seen, as you can see on the left pie charts, to have a much higher rate of early stage, that is stage 1 hepatocellular carcinoma, as opposed to the control group where more advanced stages 2 and 3, were diagnosed. And again, when you diagnose hepatocellular carcinoma at a later stage, it's not that you don't have options, but you have fewer options, and you have, most importantly, fewer curative options available to you. So again, screening this population is exceptionally important in your management of those who have hepatitis B. And again, this just shows the impact of screening on survival after a diagnosis of hepatocellular carcinoma, just showing in the screen group, which is in blue here. You can see here that over a 5-year period, the survival rate was much higher than it was in the control group, where by 5 years, the survival really was quite dismal. So the AASLD guidance for hepatocellular carcinoma and hepatitis B surface antigen positive patients is shown here. And this again includes all persons with cirrhosis, men from endemic countries greater than 40 years and women greater than 50 years of age. Persons from Africa or can be screened at an earlier age, as early as the third decade of life. And first-degree family members with a history of HCC should certainly be screened. And there is a PHB risk score calculator greater than 10. Again, is also indication to initiate hepatocellular carcinoma surveillance. And again, the method right now, ultrasonography and serum alpha-fetoprotein. And this should be done every 6 months. Another important aspect of hepatocellular carcinoma screening that came from the guidance was that there were now standardizations as far as the visualization score. So we use ultrasonography, and the quality of ultrasound can be highly variable. And one of the most helpful measures has been this introduction of a visualization score, which can be A, B, or C. And again, visualization score A, this means no lesion seen on an ultrasound, AFP normal, and you can move forward with an ultrasound and AFP every 6 months. A visualization score of B, or a lesion less than 1 centimeter on ultrasound and AFP normal, these individuals should have a repeat ultrasound in AFP in 3 to 6 months and an AFP in 6 months. And if stable, you can return to repeat ultrasound screening every 3 to 6 months and AFP every 6 months, of course, depending on the clinical context. If there is subsequent growth with this lesion, then diagnostic contrast-enhanced multiphasic imaging is warranted, axial imaging, and this is MR or CT scan with subsequent decision-making based on your CT or MR results. If you have a visualization score of C with no lesion or a lesion less than 1 centimeter, then you have multiple options. You can perform screening with contrast-enhanced MRI and multiphasic CT. And with the growing prevalence of MASL-D and also with sometimes, the limitations of ultrasound, sometimes it is just difficult to see the liver thoroughly, and one can either consider a repeat ultrasound in some patients, or you can transition to MR or CT. And some of us under these circumstances may just alternate MR or CT and ultrasound in these individuals to make sure that they aren't developing a small hepatocellular carcinoma, with subsequent follow-up based on the results of these imaging. If you do see a lesion greater than 1 centimeter on ultrasound and the AFP is greater than 20 or is increasing, then you need contrast-enhanced multiphasic MR or CT scan to either confirm or refute the presence of a small hepatocellular carcinoma. So what about monitoring patients who are not treated? So those that aren't treated, liver panel every 12 weeks with an HBV DNA every 12 to 24 weeks. And I typically do this for the first year. And after that, if I am very satisfied they have inactive disease, I sometimes bring them back twice a year. E-antigen anti-HBe should be done annually for e-antigen positive individuals. Surface antigen can be tested every 6 to 12 months in those who are e-antigen negative with persistently undetectable HBV DNA. Again, a small percentage of individuals will clear surface antigen on nucleotide therapies, but it's very small. Then, of course, you have to screen for hepatocellular carcinoma in your appropriate populations. What about monitoring individuals on therapy? Typically, liver panel every 12 weeks, and this is particularly important in the first year that you initiate therapy, and this is also true for HBV DNA. Our first-line therapies that we've discussed, they are very, very potent and highly effective. Resistance is essentially not a concern, but compliance is a substantial concern. And you want to make sure that your HBV DNA is falling, that is, they're actually taking the medicines. E-antigen positive, again, for those who are e-antigen positive when you initiate therapy. And the surface antigen should, again, be tested periodically. I typically do it every year in these individuals who are on treatment. And again, if you are on a therapy such as tenofovir disoproxil, or very, very rarely nowadays adefovir, then you need additional monitoring for your creatinine every 12 weeks for the first year, and you need to look at some tubular proteins as well within the urinalysis. So we're going to wrap up here and then turn this over to a discussion. Appreciate your attention this afternoon. But to summarize, the role of quantitative surface antigen is evolving as it becomes increasingly recognized as a valuable tool in various aspects of disease monitoring and treatment decision-making. This means prognosis, treatment response, guiding treatment decisions, and this will become more important with our emerging therapies. The goal of hepatitis B treatment functional cure is to achieve surface antigen clearance, which leads to sustained viral suppression, and again, a whole host of other positive outcomes, including reduced risk of liver-related complications such as cirrhosis and hepatocellular carcinoma. There are novel new therapies that are in development that may help achieve functional cure, and the preliminary data that we saw today with bepirovirsen was just highly encouraging, and looking forward to additional trials that are going to be reported. Don't forget to screen your patients for hepatocellular carcinoma. AASLD recommends HCC surveillance in all adults with chronic hepatitis B infection and cirrhosis, as well as other selected HBV populations. Those of us in practice do individualize our HCC screening strategies. And again, when you begin the surveillance program, HCC screening is a hepatic ultrasound and AFP every 6 months with subsequent follow-up based on these results. I think I'm going to stop here and turn this over to Dr. Jacobson, and thank you so much.
Thanks so much, Paul. That was great. So we have quite a few questions from the audience. I'll start with one of them, which is, what about stopping therapy in a cirrhotic patient who has S-loss in therapy? Nancy, just keep them on it to be ultra safe, or stop at some point?
Yeah, my cirrhotic patients really make me the most nervous. I think if you have surface antigen loss, and I wouldn't take just one, I would probably do it more than once, and your patient was well compensated, you could have a discussion about very close monitoring. But I think that, truthfully, I would just plow ahead and not take that risk in a cirrhotic. Ira, you?
I'm afraid to stop. I generally continue. I'm afraid that a reactivation, even if not likely or very unlikely after a couple of years, could result in catastrophe for the patient.
So I had a patient who was stubborn and wanted to stop, in fact, demanded and stopped. And 2 years later, the surface antigen recurred. And so we fortunately were monitoring him, but based on that one N of one, I, in that population, would encourage continued nuke.
Were there any clinical consequences to that?
Just a stern talking to by me.
So it could have been worse, at least.
Yeah.
Got away with. You didn't get away with it. He did. That brings up another point. What about continuing to surveil for HCC in, let's say, non-cirrhotics? Cirrhotics obviously need indefinite screening. No fibrosis, mild fibrosis, functional cure.
Right.
Do you continue forever, or do you stop?
I like the idea that if you have the threshold that you're going to treat, you're treating for decrease in long-term outcomes. Unless you lose surface antigen, you still have risk. And so I do screen anyone that I have on therapy. And remember that cancer risk increases as we age. So although you have beautiful data showing that integrated DNA might go down with prolonged NA therapy, it doesn't go away completely. And the last thing you want to do is to miss early cancer and to have that horrible 5-year survival when we could have curative therapy. So I do not stop.
Is that age dependent? There are data suggesting that if you're over 30 or 40, that your risk of liver cancer persists, but perhaps not in very young people.
I mean,
I agree with you, by the way.
Yeah, I think that we are going to get smarter about this disease, right? And it might turn out that genotype and quantitative surface antigen or other metrics, whether it's a measurement that we're not even looking at yet, could add to that. But I think that there are other health consequences. You might have lowered your risk of Hep B-related cirrhosis, but in my practice, you've added alcohol, obesity, and diabetes. And so I plow ahead.
Yeah, and in a similar fashion, Ira, I think it will be an opportunity for us as we have more therapies that actually achieve functional cure. I think we're going to get more robust data sets that will allow us to make better recommendations. But I think all of us have been, for instance, in clinic or on service where you have someone who is core antibody positive come in with some horrendous hepatocellular carcinoma. And again, I agree with you. If you're really young, then I don't necessarily recommend surveillance. But above the age of 30, I'm just, if I'm the one who's documented the surface antigen clearance, I still bring them back.
All right, now let's forget about surface antigen clearance. You've got a hepatitis B patient in front of you. They still have surface antigen, perhaps on therapy. When do you start surveillance?
So
we know what the guidelines say.
Yeah.
Right? It's age dependent.
Yeah.
Or it's dependent on
So I bring these individuals back on a regular basis. It is something that if you sit down with somebody, and I think we've had these conversations where you can say, well, the guideline was that you didn't have to be screened. That is zero consolation to a young person with a really widely disseminated hepatocellular carcinoma. I screen these individuals for this reason. It's one of the, in my opinion, least pleasant conversations that you can have. And again, it does go against the guidance. It does seem, though, that, you see someone at age 18 who has hepatitis B, and you say, great news, the next ultrasound will be at age 40. And so that just doesn't seem quite right to me. And so I bring these people in for screening. It would be great if we had better biomarkers, Ira.
So to be clear, you're getting ultrasounds every 6 months in patients, all adult patients, because you only see adults.
Yeah, yes. And you tell them, you try not to have them dwell on it. But on the other hand, I would say that most of our patients don't object.
Nancy, for you?
Yeah. I do 6-month surveillance, probably around 30, unless my patient's Black or African, and then it's as soon as they're my patient. And I do annual before that, which is definitely not in the guidelines and probably isn't ideal, but I have a little trouble engaging them as I need to learn Paul's stern talking to, I guess.
Okay. When using quantitative S testing, are there data to support or different treatment stopping rules for patients with a strong family history of HCC? Certainly family history bears on surveillance, although this group of 3 people is pretty all-encompassing anyway.
We were
surveilling. The guidelines, family history means you take the age out of it. But what about that particular question? Paul?
So the surface antigen level doesn't really affect my inclination to begin screening for hepatocellular carcinoma, Ira. I mean, especially if there's a family history, that to me is essentially an automatic. And we will go to great lengths to make sure that these individuals are screened regularly.
Mm-hmm. Okay. What about co-infected patients, HIV co-infected patients? We are awaiting data from future studies on novel agents in HIV co-infected patients. I don't think we have anything else on that right now.
Yeah, other than, Ira, that there are now non-nuke-based HIV regimens that are available, and there are rare cases of reactivation because people are transitioned off of this. And so we just have to be very mindful of this. And we now are bringing people back. There are some reports of really substantial reactivations that have occurred just because HIV therapy backbone works so well for hepatitis B as well.
Yeah. What's the best ALT value to use for upper limit of normal in men and women, Nancy?
I mean, I think that 20 and 35 are probably easy to remember, as opposed to the 19 and, but definitely not what your lab says is normal.
Do you say 20 and 35 or 25 and 35?
I do 20 and 35, which is definitely not because I think that the 19 to me is the same as 20, and these are numbers that are easy to remember. But remember that young people and healthy people have much more normal values than we expect. And sometimes your labs are like 7 and 10. And so I use a much lower threshold in my women.
All right. Paul, you too?
Yes. So since I wrote one of the guidances, I'm, of course, biased toward my own. So 19 and 33. But the AASLD uses 25 and 35. And those are all perfectly reasonable guidances to use. And again, we see a lot of people now who have hepatitis B, Ira, who have MASL D, and we'll see higher levels for that reason.
Question I really like because it's going to help us make a fundamental point. I mean, I really like all the questions. But is there a role for checking HBV mutations in E-negative normal ALT HBV DNA 1000 and minimal hepatic fibrosis to differentiate carriers from HBV mutations associated with more aggressive disease and higher ACC risk? And I think the answer here is to understand that the mutations that lead to oncogenesis are not mutations that you can access with blood tests, at least in the current era. So we're talking there about mutations that come about from integration of the portions of the HBV genome into the host genome. and disruption of genes within the patient's own chromosome. So in the current era, we can't measure those. It's a fascinating question one day. What we'd love to be able to do is measure HBV DNA in the blood and figure out how much of it is coming from integrated DNA, which can still express surface antigen. And many authors think the X antigen or protein, but not the others, not polymerase or core. And one day we'd love to be able to have serum assays to differentiate the source of the patient's HBsAg, because it'll really inform what we're accomplishing with various novel agents. Ultimately, we'd like to completely eradicate cccDNA, so we'd love to be able to measure that fraction. And we'd also like to silence, we're not ready to have a technology yet that can, literally, unless you develop excisional genetic therapies, which are actually in the offing preliminarily, to remove the DNA from the chromosomes with things like CRISPR. But there are also non-excisional approaches. That's all very fascinating, but it would help in all of our development programs, which we can't do now, to determine the source of the DNA and how much is one fraction versus another. Can't do it. With the WHO guidelines, which is virtually treating everyone, are we equipped to cater to all the patients presently? That's a very interesting question. And you want to take a crack at that, Nancy? Well, you had a thought.
We definitely recognize that there is a huge workforce shortage, but I think that we also have to know that the best provider for a person with hepatitis B is an educated person that is comfortable treating Hep B. It does not have to be a hepatologist. And so I think if we can identify the patients and link them to someone that is comfortable treating them, we have to be creative with those educational models.
And the guidelines are simplified now. I completely understand a decade or 2 decades ago why it was complicated and people shied away from treating hepatitis B. You covered today several guidances, which I think will allow primary care physicians with appropriate education to care well for these individuals. So I think the workforce can expand.
Does the presence of hepatic steatosis in patients with chronic hepatitis B increase the risk of HCC? And I think we can take that question as being independent of the context of fibrosis, because if it's fibrosis, we know what the answer is. Nancy?
Yeah, yes, absolutely. I mean, hepatic steatosis, even without hepatitis B, increases HCC risk. And so it absolutely is going to increase that risk, which is why the WHO has added obesity and metabolic factors to reasons to treat independent of DNA.
You're not suggesting surveillance for HCC in every patient with steatosis, though.
Well, the debate today, our team is debating Amit Singhal. That's got to be a bad debate, but it is on screening in patients that are not cirrhotic. And I think that we can't, talking about capacity, it would be very challenging to screen everyone who has steatosis. But I think if I had a patient who is Hep B and has steatosis and does not have fibrosis, I will be screening them for HCC. But I was already screening everyone anyway, so.
Yeah, and we talk about the high prevalence rate of hepatitis B worldwide, Ira. If we start talking about the prevalence of steatosis, there aren't enough ultrasound machines in the world to cover these individuals. So I think we have to have a more targeted approach. But hopefully, again, here, I think if we develop biomarkers, this is a place where I think we can maybe have more tailored approaches to these individuals, and maybe even develop polygenic risk scores, just depending on risk alleles, that might allow us to come in and tell somebody you're going to be at a higher risk for a liver-related outcome, and and someone else, conversely, their liver-related risks may be lower.
Mm-hmm. Here's something that comes up a lot: the significance of surface antibody in our work with our patients. We know what it means when we're talking about vaccination and immunization, but that's not the point. When a patient self-clears and develops immunity to Hep B, positive HB surface antibody, is there a chance to still get cancer? Do we still screen for cancer periodically? Now, I'll preempt both of you by guessing that neither of you will say you predicate your surveillance strategy on whether there's surface antibody or not. But let's generalize that a little bit, all right? We're looking at surface antibody in our patients who are taking these investigational treatments. And the debate right now is whether the appearance of surface antibody at the end of a course of therapy is a good thing, particularly in patients who clear HBsAg. Are the patients who have detectable and perhaps even more importantly, high levels of HBs antibody less likely to relapse their surface antigenemia in the future? than others. We don't really have an answer to that, but one is beginning to emerge from the HPV cure meeting on Tuesday. I don't know if you went, but there are emerging data suggesting that you're better off having high surface antibody titers, if at all, and including hepatitis B antibodies in the first place, than not having them. We know that after nuke therapy, patients stop. About half of them, I think, have surface antibody, but then the others fall in place as the years go by. But I think the truism till now has been that with conventional therapy, surface antibody appearance at the end of a course of therapy doesn't necessarily mean something better for those patients than those who don't have surface antibody. Recurrence of HBsAg or antigenemia is still pretty unusual. Do you agree?
Yes.
Do you look at it?
Yes. We don't have a lot of data in novel therapies, but I agree with you that when you pharmacologically drive down the surface antigen to produce a surface antibody, the natural history of that, I think, is going to be different than someone who's not on therapy, who over decades surface antigen clears and they produce surface antibody. And we will hopefully have robust data sets that will be able to help us correctly interpret these individuals' response rates.
It's certainly being looked at with great interest in all of our novel therapy studies. Nancy, do you have a comment?
I would just remind people that you can be surface antigen positive and surface antibody positive. So I wouldn't interpret the surface antibody outside of the context of the other markers.
Nancy, when would you treat a so-called immune tolerant patient?
Oh, we don't have the right answer to that, right? So I think that we need more information and knowing if you treated someone who is younger, if you have better long outcome, then I would want to be treated as early in my life as I could be convinced to take pills. I think that the reason that 30 is in there is to allow you have that natural ability to seroconvert, which has durability. But if there's a family history or you have a nervous person, I don't use 30 as a hard stop. I think 29, 28, and 30 are probably about the same age. And so if I have a willing individual, I have a family history of liver cancer, liver cirrhosis, I will treat as early as my patient's willing to take therapy.
And also the other thing over time is the stigma associated with hepatitis B. And that to me is a perfectly appropriate reason to initiate treatment.
And to me, if you think about all that DNA that's getting integrated on an ongoing basis, it just makes more sense to think of it as a virologic issue.
You had a compelling set of slides on that, right?
Yes.
Thank you. In the BEPI phase 2 study, though 9 to 10% reach functional cure, did patients show trends toward rebound? I'm not aware of data suggesting that later relapse occurred beyond that time point, but I'm sure that'll be reported out.
Yeah, we just need more time.
Yeah. Paul,
Yeah, I agree.
How many subjects in Be Clear and Be Together lost HBsAg and are still on nuke therapy? What is the rate of subjects who are off all therapy after 6 months? Standing up here right now, I mean, the population I can speak about most clearly, I believe, is the Be Clear study. How many subjects lost HBsAg? I showed you that. And I don't have an exact number, but most of them were off nuke therapy. They met nuke stopping criteria.
Okay.
Yep. Okay. Questions are still coming in. Is COVID-19 the only reason to explain the difference of S loss in Arm 1 and Arm 2 from Be Together study? That's a very good question. I've wondered about it myself. Professor Booty has had to leave. I can't ask her directly. I would have liked to. It's in one passage in the results section of that paper in Lancet, and nobody really attempted to stratify out how much of it is that effect versus others. It's hard to believe that there's really a virological advantage or an antiviral advantage in taking BEPI for 12 weeks followed by 24 weeks of interferon rather than the initial 24 weeks. So just intuitively, I expect that is a large part, if not the entirety of the story.
Yeah, we'll have to see in other trials, and I'm sure BEPI will be combined with other agents, and we'll have to see if you see the same duration signal, right? I think it's just time will tell. We blame so many things on this COVID era, so it just seems like this is something, it's a reasonable explanation.
Yep. We have about 5 minutes left. Paul, do you get HBV genotype when you first encounter a viremic patient?
If I'm considering treatment, the answer is yes, particularly if there's a family history genotype. Yes, I will go ahead and obtain it. It's not in everyone, but yes, I do get it.
Nancy?
I get it all the time, but now I'm not using much pegylated interferon, and I'm pretty encouraging my patients to engage in therapy. And so if they come already with Hep B DNA and I don't need to get labs, I'm not going to do a genotype.
Yeah, I used to get it also, and I even remotely considered interferon, which I frankly don't anymore. I do tell the patients about it. Nobody wants to take it. Perhaps I'm a little biased in my presentation of the matter, but in any event, I don't get it anymore. However, I do think we can acknowledge that it's important to integrate that information into the analyses of outcomes of investigational therapy studies, because there may be a gene, and that's exactly what one of the bepirovirsen abstracts is about at this meeting, as I showed you. Okay. I think we've covered a lot of these. Are there any other points you'd like to bring out, Paul? Any summary comments? So I think we're just about nearing the end of this.
No, other than I think, Ira, what we've shown is that we have the tools to make a major impact on reducing the morbidity and mortality of hepatitis B now. And it's just a treat that now that we may be able to start seeing an era where we're achieving functional cure. My absolute goal would be that before I retire, that hepatitis B surface antigen rates are like DAA success rates for hepatitis C. And if that happens, we'll be treating everyone.
Are you making your retirement conditional on having cured
No.
hepatitis B?
I like that. You're going to be my partner for a while.
Well, it looks like Paul probably will be able to retire. Things are going in a promising direction, but we still do have a journey ahead of us. If you look at the results of the most impactful studies so far, the BEPI study, 10 to 15% of patients, we've got a long way to go, and there is a very robust development program surrounding that agent, but also many others. The investigational products that are being pursued are more novel than ever, including a variety of immunologic.
But it is our first meaningful foot in the door.
That's right. We'd like to thank you for coming. Thank you so much for joining us. We hope you found it helpful.
Thank you for listening. Remember to download the slides and practice aids and complete the post-test for instant credit. This activity is certified by PVI, PeerView Institute for Medical Education. This educational activity is supported by an independent medical education grant from GSK. To access all materials for this activity, visit peerview.com/STZ860.